Hi, my name's Heather Walker, and I'll be presenting my critical thinking assignment. Subjective data, chief complaint, non-healing wounds to bilateral lower extremities. The history of present illness. This is a 101-year-old female being seen for wound assessment of venous stasis ulcers to bilateral anterior lower extremities. She has a significant history of ischemic heart disease, Alzheimer's disease, heart failure, chronic kidney disease stage 3, hypertension, and venous stasis ulcers to bilateral lower extremities. Wound care was changed to Metahoney Alginate 1 month ago, and she has been treated with Keflex and doxycycline in the past 3 months for wound infections. Nursing staff at the facility reports patients' wounds are not healing and there is increased drainage. Her medications include Ativan, PRN, metoprolol tartrate, tramadol, 3 times a day as needed for pain. She does take scheduled Ativan daily for anxiety, Senna, Lasix, Celexa, Tylenol, a multivitamin, Miralax, and her allergies are to amlodipine and lisinopril. Her past medical history, illness and injuries as an adult include Alzheimer's disease, ischemic heart disease, heart failure, stage 3 kidney disease, hypertension, venous stasis ulcers to bilateral lower extremities. Hospitalizations, she hasn't had any recent hospitalizations. All of her vaccinations are up to date per her immunization record. Health maintenance, her last complete physical was completed a month ago. Family history includes her mother and father had hypertension, and her maternal grandfather died in his 70s from liver cancer. Social history, she was born and raised in Coopersville, Michigan. She was assigned female sex at birth and identifies as a female. She's widowed and has 4 adult children. She lives in long-term care and has Medicare. She does not attend church, but identifies as a Christian. She has a DNR order, and her daughter is her medical power of attorney. She does not use tobacco or alcohol or illicit drugs. Review of systems. She denies fevers, chills, fatigue, or night sweats. Her skin, she denies rashes and itching. She does report wounds to her lower legs. She denies double vision and eye pain, has glasses for reading, denies ear pain, tinnitus, denies hearing aid use. Nose, mouth, and throat, she denies loss of taste or smell, sore throat, difficulty swallowing, denies mouth pain and bleeding gums. The breast exam was deferred. Cardiovascular, she denies chest pain, palpitations, and swelling in her feet. Denies orthopnea, dyspnea, and cough. Denies nausea, vomiting, diarrhea, constipation, hemorrhoids. Denies any recent weight changes and reports her appetite is poor. She denies dysuria, urinary urgency, frequency. She is incontinent of urine. She does report. She denies muscle pain and stiffness. And for neurological, she denies any numbness and tingling, seizures, syncope, depression, and sleep disturbances. For physical exam, her vital signs were all within normal limits. She does weigh 89 pounds, and she's 4'11", making her BMI 18, so very tiny lady. She's, as I said, a 101-year-old Caucasian female who appears at her documented age. She's alert and oriented to self only, although she is able to answer most of the questions appropriately. At time of the exam, she was seated in her recliner in no apparent distress. Lower legs with venous stasis ulcers, which are open to air for the exam. She was agreeable to the assessment for her wounds. Her skin is pale and cool to the touch. She has venous stasis ulcers to her right anterior lower extremity and measures 1.2 centimeters by 1 centimeter by 0.2 centimeters. And she has a venous stasis ulcer to her left medial ankle measuring 0.5 by 0.7 by 0.2 centimeters. Wound bases are covered 100% with yellow slough. No odor, warmth, tenderness, or redness present to surrounding tissue. Wounds are draining a moderate amount of tan drainage. As far as her head, eyes, ears, nose, and throat, as you can see, there's really no significant findings there. For cardiovascular, same thing, no significant findings. And the only positive finding there was that her pedal pulses and post-tibial pulses were not palpable bilaterally. She did have trace edema to bilateral lower extremities. No respiratory concerns. For gastrointestinal, bowel sounds active, no masses, no guarding, no tenderness. She is incontinent of urine. No muscle tenderness or weakness present in bilateral lower extremities. She does require assistance with transfers. No swelling over her joints. Neurological, she's pleasantly confused. Mood and affect are appropriate for the situation. Her hand grasps are equal bilaterally. For her labs, her significant results were that her total protein was 4.1, her albumin 2.5, her globulin 1.6, and her calcium 7.6. She also has a hemoglobin of 8.5. For the assessment, the differential diagnoses include chronic venous stasis ulcers to bilateral lower extremity, peripheral vascular disease, chronic venous insufficiency. And the diagnoses include chronic venous stasis ulcers, and venous stasis ulcers are shallow wounds that occur above the ankle and are caused from venous insufficiency. And she also has protein calorie malnutrition, which is the diagnosis that I'm focusing on for the rest of this presentation. Protein calorie malnutrition is loss of body protein resulting from insufficient protein intake or increased requirements in disease. It's one hallmark of malnutrition, followed by an impaired immune status and loss of muscle mass, which contributes in large to the increased morbidity observed in malnutrition. The plan for this patient, the wound on her right anterior lower leg and left medial ankle have 100% yellow slough to the wound base. The wound nurse at the facility reports there was slight improvement to the right lower leg wound, but that the left ankle wound was stalled. Current wound care consists of cleaning the wounds with saline, patting dry, covering with Meta-Honey alginate, and wrapping with gauze, and they were changing the dressing daily. The new wound order for these wounds include cleaning with saline, pat dry, apply thin layer of Triad by Coloplast, cover with nonstick dressing, and wrap with rolled gauze, and to change the dressing every 3 days and as needed for increased drainage. Triad is a hydrophilic wound dressing that can be applied anywhere on the body and adheres to wet skin while keeping the wound covered to facilitate healing and debridement. The plan going forward to reevaluate the wounds in 2 weeks and to consider a hospice referral due to her advanced age, poor oral intake, multiple infections, and non-healing wounds. Protein calorie malnutrition. This patient's 101 years old. She has a poor appetite. She's completely dependent on facility staff for all cares. And she has these venous stasis ulcers to bilateral lower extremities that have been there for over a year. Her labs, her poor appetite, and her clinical presentation contribute to her diagnosis of protein calorie malnutrition. And she has a poor prognosis due to her advanced age, malnutrition, history of infections, and multiple comorbidities. Goals. This patient has non-healing venous stasis ulcers related to protein calorie malnutrition and peripheral vascular disease. Her children were contacted to discuss goals of care moving forward. Her daughter was updated on patient's wound status and barriers to healing, including her poor nutrition and poor circulation, and of course, advanced age. Her daughter reported that her and her family's goals was for the patient to be comfortable and verbalize understanding that these wounds would likely not heal due to all of these given factors. Her daughter was receptive to the idea of a hospice consult. The short-term goals for this patient include infection prevention and pain management, and long-term goals is for increased quality of life. The only barrier for providers with hospice referrals are if the family disagree with the decision to involve hospice care, or if the patient doesn't meet hospice criteria. So I'll explain a little bit about hospice and kind of explain why this patient would benefit from a hospice referral. Hospice is a Medicare benefit, which is covered 100% with no cost to the patient. It's also covered at 100% by most major insurances. It provides a service that provides medications, durable medical equipment, personal care items, catheter supplies, and wound care supplies. So really decreases the cost burden to patients and their families for those needed supplies. Hospice is a service provided to patients with life-limiting illnesses who have a prognosis of 6 months or less. And that is determined by two physicians, one being the hospice medical director and usually the patient's primary care physician, who both agree that the patient is terminal. And hospice focuses on quality over quantity, and the goals of care are palliative. With hospice, there's an interdisciplinary team approach to care, which focuses on care of the whole patient, including mind, body, and spirit. The hospice team guides care in collaboration with facility staff, works with the patient's PCP, and does not replace the current caregivers. So it's really a blanket of services or support, both to the patient, the facility staff, and to the family. Hospice does have bereavement services for the family for 13 months after the patient's passing to help with the grieving process after the patient's gone. There are several hospice agencies in West Michigan. Some of the most popular hospices in our area include Faith Hospice, Emmanuel Hospice, Hospice of Michigan, and Spectrum Hospice. Of course, this is not a full list, but just some of the most common in our area. Patients and families are given the names of the hospice agencies and can interview different agencies if they'd like to be able to make a choice there. The nurse practitioner or healthcare provider sends a hospice eval order to the agency of patient's choosing, as well as recent medical documents that support patient's eligibility. And then from there, hospice takes over and does their assessment. If they find that they are eligible, they will admit them under their care. Hospice has a lot of wonderful things to offer, but like I said, the biggest ones, improving quality of life for patients and supporting not only the patient, but the caregivers and the family. So a wonderful resource and actually often underutilized. For reflection for this case, this assessment was straightforward and easy to complete. The patient was cooperative and pleasant. Patient has had these chronic venous stasis ulcers for almost a year, and my preceptor has tried several different wound treatments for this patient. This case is complicated by the patient's poor circulation, malnutrition, and multiple chronic conditions. This patient received supplement shakes for additional calories and protein to help with wound healing, although with no success in the past year. Triad was a good option for this patient for wound care, as it's inexpensive compared to some of the other topical debridement options, and it was recommended by the wound specialist in the facility due to the amount of slough present and the non-healing status of these wounds. This patient will not likely heal due to the several factors mentioned before, and would benefit from hospice care if she meets eligibility criteria. This case was beneficial to me as a future nurse practitioner, as hospice referrals can be difficult to initiate due to the sometimes uncomfortable conversations that lead up to hospice referrals. So really does help as a student to be able to get experience with having some of these more difficult conversations. And here are my references.